Good morning, friends. Happy Diwali to you all. We are here again with our new episode of our monthly webinar series, which was started about, I think, 2 years ago. So today it is our 22nd episode. And we plan to continue it further as well, as long as we can. The topic for today is approach to hepatomegaly. I am Dr. Anupam Agarwal from dockieslive.com, which is an educational initiative by GP Clinics, which is our flagship journal being published every month for last 15 years. I thank all our readers for giving us an overwhelming response to GP clinics all these years. Just for your information, many new features have been added in GP clinics recently in the form of diagnostic quizzes, practical pointers, 1-minute quiz, did you know, darkroom secrets, which is about reading chest x-rays, and many more such useful features to enhance clinical practice for GPs and primary care physicians. More so, we have been receiving inquiries for its subscription from many countries now. Friends, the recordings of all our previous webinars are available on our website, gpclinics.in, and on our YouTube channel, dockieslive.com. Also, the summary of each webinar is published in GP Clinics print edition every month, with answers to all the questions asked here. Dr. Y.K. Amdekar is the speaker for today's session as usual, who has been into practice for last 50 years. We are obliged to have his expertise and knowledge month after month. So over to you, Dr. Amdekar, sir.
Thank you very much, Anupam, and good morning, friends. Today we are going to discuss a clinical sign which often is the only presenting feature in a given patient. Like a patient may come only with an abdominal distension and you may find the liver is enlarged. He may or may not have any other symptoms, and we will discuss how to approach such a problem. Can I have the next slide, please? Now, as usual, we will consider the basics of what we are going to discuss. The first and the foremost is when we say hepatomegaly, we are talking about an enlargement of the liver. Friends, liver could be normally palpable, especially in infants and young children, and sometimes it could be palpable because it pushed down from the chest, but it may not really mean hepatomegaly. Therefore, when we say it's an enlarged liver, we need to monitor and assess the length of the liver enlargement, or what is referred to as span. And how do you pick up a span of the liver? Just not by the liver getting more palpable per abdomen, but the distance between an upper border of the liver and the lower border of the liver. Upper border of the liver is not palpable because it's in the chest, but it is percussible. So you percuss from the second right-sided space, intercostal space, which is tympanitic because there is an air in the lung there. And then when that tympanitic node changes to impaired node, you know that that's an upper border of the liver. And then the lower border of the liver is easy to palpate per abdomen, and the length between the upper percussible border and the lower palpable border is called a span of the liver. And the span of the liver is generally varies from 6 centimeters at birth to almost 12 centimeters in older children and adults. And roughly, it increases by 1 centimeter in the first 2 years. So it becomes 7 centimeters at 1 year and 8 centimeters at 2 years. And thereafter, every 2 years, it goes on enlarging till it reaches 12 centimeters, which is an average older children and adult liver span. So please confirm that the liver is enlarged, because sometimes the liver may be pushed down but not enlarged, or occasionally you might find even a normal person having a liver enlargement. Having said that, every hepatomegaly is not a direct hepatocyte disease or a liver disease. And therefore, it's important to further define clinically what is the not only the span but also consider the consistency, whether it is soft, firm, or hard. Normally, the liver is just soft, but as it starts getting pathological, it starts getting more and more firm. And a very hard liver is obviously either a cirrhosis of liver or even the malignancy. And the surface is generally smooth. But if there is a hobnail type of a cirrhosis or a surface which is uneven, not smooth, then we know that there might be some knob-like structures often seen in cirrhosis, or it could be a one big knob like any localized tumor. The border of the normal liver is just a leafy, which means it is just palpable, but it could be firm or it could be even hard. And normal liver is obviously not tender. So we clearly know how to go about such details, and it's important therefore that when we clinically look at this, the liver is enlarged. But don't forget, before we go further into understanding hepatomegaly, the liver has four parts for a clinician to understand. I repeat again, liver has four parts for a clinician to understand the anatomy of the liver disease. One is, of course, hepatocytes, which are liver cells. Another is a biliary tracts. The third is a venous system. You know, the liver has two types of venous systems, the portal venous system and also the general systemic venous system. And then the fourth component of the liver is reticuloendothelial cells. We will see how to apply this, but remember, when you say the liver is enlarged, it may be important for you to say which part of this liver is enlarged. Is it a hepatocyte, biliary tract, venous system, or a reticuloendothelial cell system? Can I have the next slide, please? Now we will quickly go through the causes of liver hepatomegaly, but the main groups are primary liver disease or secondary liver diseases. Primary liver diseases are largely of three or four types, and every time you have a primary liver disease, you consider these four types. The most common is viral infections like A, B, D, E. Okay, there are many other viruses which are not common. So one is a group of infections, mostly virus. Of course, bacterial infection can also affect the liver, like tuberculosis, leptospirosis, brucellosis. Okay, many such things, or for that matter, liver abscess or cholangitis are all infective, bacterial infective liver disorders. But they are not so common. Viral are very, very common. So one group is infection. Another is an autoimmune hepatitis. Autoimmune hepatitis generally is an immune-mediated disorder, and we will discuss about these during our case scenarios. The third group is a metabolic liver disorders, and these are not very rare, especially a Wilson's disease, where the copper is getting accumulated, and some rare storage disorders form this metabolic group. And of course, you may have other fourth group, which is the damaged liver, either because of a tumor or because of a cirrhosis, or sometimes it could be simply a venous obstruction, like a hepatic vein obstruction or an inferior vena cava obstruction. Or finally, it could be reticuloendothelial cell disease, where something is accumulating there. What is most simple is, for example, in a hemolytic anemia, the liver is enlarged because of hyperplasia of the reticuloendothelial system. So these are the types of primary liver diseases, and secondary liver diseases are due to extrahepatic causes. Again, infection comes into play, and these infections are largely typhoid, malaria, leptospira, tuberculosis, sepsis. You have a storage where the problem is outside the liver, often cardiac diseases present with hepatomegaly, like a congestive cardiac failure or a constrictive pericarditis, where the superior vena cava or inferior vena cava is obstructed and you might get a hepatomegaly. And finally, as I mentioned, the hematological disorder. So, friends, every time you have a hepatomegaly, confirm which part of the liver is likely to be contributing to the hepatomegaly, and then also consider etiologically whether it's a primary liver disease or a secondary liver disease. Can I have the next slide, please? The next slide, please, is a clinical approach. So when you confirm that the liver is enlarged, that is hepatomegaly, first consider the major groups with jaundice and without jaundice, because this is easy to go by. With jaundice are, of course, the typical infective disorders, which are hepatocyte disorders, but the biliary tract disorders often end up with the hepatomegaly. To begin with, biliary disorders do not have hepatomegaly, but very soon, when there is the biliary stasis, the bile ducts are accumulating bile for varieties of reasons. This bile seeps into hepatocytes and also causes a hepatocyte disease. Hence, friends, it's important in every jaundice to find out whether the jaundice has started in hepatocytes or has started in a biliary tract. And how do you do that? A biliary tract disease is generally a very severe jaundice, often with clay colored stools and itching as a prominent clinical symptom. But on examination, there is often no hepatomegaly. That's the beginning story of a biliary tract disease. And more important, to begin with, the health is reasonably maintained till the disease causing biliary obstruction worsens or the disease spills over the hepatocytes and causing hepatocyte disease secondary to biliary tract disease. The classical example being biliary cirrhosis or a beginning of a pancreatic malignancy in an old man where obstruction causes a biliary stasis, but very soon, because of a malignant tumor growing faster, there are constitutional symptoms and the health starts going down. But on the other hand, a typical hepatocyte disease has a mild to moderate jaundice. Often the jaundice is not very severe, but the health is upset very early because the hepatocytes are concerned with multiple metabolic functions and multiple productive functions. And therefore, when hepatocytes are damaged, the health is upset. But if the biliary tract is damaged, the health is not upset unless the cause of biliary obstruction gets worse or the biliary disease spills over to the hepatocyte. So it's easy. Every time you see a hepatomegaly, look for jaundice, confirm it's a high colored urine, and if clay colored stool and itching, it's a biliary tract disease with severe jaundice and a reasonable maintained health. On the other hand, a mild jaundice, not clay colored stool, nor itching, and a health getting upset is a hepatocyte disease. That's the first group. Well, there are some other parts of the liver which do not cause jaundice but cause hepatomegaly. And that's largely concerned with hepatic infiltration of an RE cell. These are chronic infections that we talked about. They also are storage disorders or a very localized liver disease like a benign hydatid cyst or a hepatoblastoma. The cancer of the liver is a localized tumor, and because it's a localized tumor, it does not present with jaundice. Similarly, the storage disorder, or for that matter, a venous obstruction, like a portal venous obstruction or a congestive cardiac failure, these hepatomegaly, in other words, hepatomegaly with jaundice is either a hepatocyte or a biliary tract disease, and one without jaundice is either a venous disease or an RE cell disease. So simple to go by. And what's the reason why one has jaundice and the other group has no jaundice? And the only reason is the jaundice clinically manifests only if more than 80 to 85% of the hepatocytes are damaged, or of course the biliary obstruction has come up. But in venous obstruction or an RE cell infiltration or a localized liver tumor, not so many hepatocytes are damaged, nor a biliary tract is damaged. And therefore, these, this group of hepatomegaly come without jaundice. But just to keep in mind that there could be jaundice without hepatomegaly also, like you see typically in an acute hemolysis or sometimes rare enzyme deficiencies. But that's not the discussion today. We are discussing hepatomegaly. And of course, if the liver is tender, you know there's an inflammation. If the consistency is firm, it's of some hepatomegaly of some duration. And if it's hard, then we know it's either cirrhosis or malignancy. And of course, a clinical approach to hepatomegaly cannot be complete without any other associated signs, like a presence of splenomegaly or ascites might indicate a portal hypertension. Don't forget the engorged neck veins to look at. Friends, occasionally one would easily miss a cardiac condition leading to hepatomegaly, like a chronic cardiac failure, chronic CCF, or a chronic constrictive pericarditis, both present with a abdominal distension and a hepatomegaly. And if you fail to look at the neck veins, which are engorged, then you know that it's possibly a cardiac condition. And in CCF, hepatojugular reflux is present in engorged neck veins, whereas in constrictive pericarditis, the hepatojugular reflux is absent in spite of the neck veins being engorged. So clinically, it's very easy to differentiate a cardiac disease causing hepatomegaly and in cardiac disease, CCF versus a constrictive pericarditis. And I think sometimes there could be a lymph nodes, either peripheral or even mediastinal or abdominal, and you might diagnose a disease like leukemia or a Hodgkin's lymphoma with hepatosplenomegaly. Pallor is often a accompaniment of a hemolytic anemia with a hepatomegaly, or of course leukemia or hematological malignancy. And same is true about the purpuric spots. Now, and also the bony tenderness. I think don't forget to examine every other system in a hepatocyte or an enlarged hepatomegaly case, because occasionally the problem may be in the right side of the chest. There is something occupying there, and the liver is pushed down. Liver is pushed down, so you have a large abdominal palpable liver. But if you were not to take the span of the liver, which is normal in that case, but the liver is largely palpable per abdomen. So message is always start with the span of the liver and then go further on a clinical approach. Having said this, next slide, please. We will do, as usual, different types of cases, and they will bring out all different causes of hepatomegaly and how a good clinician can pick most of them simply bedside skills. You even don't need investigation. Of course, investigations are required to confirm a clinical impression, but a clinical diagnosis is very much possible. Let's start with the first child. This is a young adult who presented with a moderately high fever that increased over the next 2 days, became more severe. And on day 5 of fever, he noticed mild jaundice. Take a note, a moderate fever in the first 2 days, becoming high fever in the next 2, 3 days, and on day 5, presents with mild jaundice. It is high colored urine. The child is febrile. He is looking sick. He has an icterus. He has a liver which is enlarged, and the spleen is not palpable. Now, what is your probable diagnosis? Choose between viral hepatitis, liver abscess, autoimmune hepatitis, or typhoid hepatitis. Your time starts now. Good. Can I have the slide back? Well, most of you have voted for viral hepatitis, though few have voted for other choices as well. What is more important is take a note of the details of the history. This child has a moderate fever which is getting worse, but the jaundice has appeared on day 5. A typical viral hepatitis is a primary hepatitis, a primary liver disease, and therefore the jaundice appears almost within the first 24 or 48 hours. A very important point of when did the jaundice appear in this child. That is number one. So typical viral hepatitis has an onset of jaundice fairly close to the onset of illness with fever. Second is often fever is mild but could be moderate as well. But the feature of a viral hepatitis A or E is a severe nausea, anorexia, and vomiting. Don't diagnose acute viral A or E hepatitis. Both come from the food or water. It's an oral transmission of a virus. Both of them present typically with severe nausea, vomiting, and anorexia. The patient doesn't even want to look at the food. The anorexia is so severe, and many times anorexia and nausea, vomiting are the first day symptoms with or without fever, but the jaundice appears on day 2 or day 3, and you can almost diagnose a viral A or E hepatitis merely because there is very little other types of diseases which come with such a severe anorexia or nausea vomiting. So therefore, this is not viral hepatitis. Now, what is the pattern of fever? The fever is moderate but worsens over the third or fourth day. And this is typically a step ladder pattern of fever. And the jaundice has come later in the course of a disease, which means that this disease has gone on increasing, worsening, and therefore this is a classical uh, case of a typhoid fever with hepatitis. Okay, I wanted to bring this difference very clearly and write in the first clinical term at second MBBS level, we have been taught always discuss origin, duration, progress of each symptom. If you looked at the origin of jaundice in this child, it has come on day 5 of fever without a very prominent anorexia, nausea, vomiting. And therefore, it is typically a typhoid hepatitis, right? But I'm happy you all came out with some infection, but this is one difference between a primary infection of the liver and a secondary infection which is outside the liver but affects the liver. In typhoid, the infection is in the intestine, but it affects the liver. Extra hepatic infection. Malaria is an extra hepatic infection. leptospira is an extrahepatic infection. And those who have an extrahepatic infection are complicated to develop a hepatic involvement. And that complication takes few days or maybe even at the end of 1 week, but not to begin with. And that's why this is not a viral hepatitis. Can I have the next slide, please? The next slide is a young adult again who presented with moderate fever and vomiting 5-7 times, followed by jaundice on day 2. Okay, make a note again. With moderate fever and vomiting is a predominant symptom in this child. Okay, followed by jaundice on day 2. Physical examination shows that this person has obvious icterus, liver is quite enlarged, it's soft, it's mildly tender, spleen is not palpable. Okay, now pick up a small difference between the first case and the second case. Okay, and now your options are, is it a viral hepatitis? Is it acute cholangitis, which means it's a biliary tract infection? Is it a metabolic disorder like a Wilson disease, or is it autoimmune hepatitis? Your time starts now. Very good. Can we have a slide back? Friends, I bring such cases on this platform only because most of you have been really reading GP clinics over few years now, or even looking at the videos, presentations that the GP clinic has been organizing, and I myself have contributed to many such episodes. And therefore, considering that the viewers and the readers of this GP clinic or all these video series are very well informed and are very enthusiastic in learning more and more. And that's why I prefer to bring cases of various differences to make you even much better informed and much smarter clinicians than an average. And therefore, don't get dejected if you are wrong. But the very fact that you attend this and the very fact that you vote for some option indicates that you have been thinking. And friends, if you start thinking, you will learn medicine. And therefore, note this case. First is the onset of jaundice has been very close to the onset of disease, right? That's why most of you considered it as a viral hepatitis. But I made a strong case that typical viral A or E hepatitis, which is common foodborne. See, viral B and C are rarely acute. They are mostly chronic. So exceptions, yes, they can be acute as well. But mostly they are chronic hepatitis, whereas A and E are acute hepatitis. This is an acute hepatitis. But there is no prodrome. Prodrome are the vague symptoms before a typical symptoms of a liver disease comes in. And the prodrome I mentioned in the first case discussion was a severe anorexia, nausea, vomiting. Without that, never diagnose viral A or viral E hepatitis. It's such a strong symptom of a viral A or E, and you can almost bet that it is going to be one of these two. And both look alike. Both have a very good prognosis. Therefore, it's hardly required to confirm viral A or E. So today it can be easily confirmed by antibody test. But the point is, therefore, it is not viral hepatitis. But take a note that this has come up very early. Whatever has come up early could be a primary hepatotropic infection like A or E, but this is not. This is obviously not an extra hepatic infection because it has come up early. Therefore, it has to be either metabolic, which comes very early, jaundice, at the onset of the disease, or it could be immune mediated. But metabolic disorders rarely have fever, and certainly not moderate fever. There could be mild feverish feeling. Therefore, it is not metabolic disorder like Wilson disease. It is not acute cholangitis because the jaundice is a predominant feature and the child is very sick, but the liver is not enlarged. So it's not cholangitis, it's not viral hepatitis, and therefore this is classically a story of an autoimmune hepatitis. Friends, autoimmune hepatitis is not uncommon in young adults or older children as well. And this is one group which affects mainly the liver and nothing else. Well, sometimes even other system may be involved, but don't forget this group of autoimmune hepatitis. And I brought out a small differences between a primary viral hepatitis and autoimmune hepatitis. Can I have the next slide, please? The next slide is a senior citizen presenting with severe itching and jaundice for 4 days, and urine is deep yellow, stool is brown yet. Okay. Now, physical examination shows he has an icterus and his liver and spleen are not palpable. Take a note of this. He has got a deep icterus coming within 4 days of illness. He has a high colored urine, so obviously it's a direct bilirubinemia. And your probable diagnosis to choose from are: is it viral hepatitis? Is it acute cholecystitis? Is it a pancreatic cancer? Or is it a biliary stones? Your time starts now. Can I have the slide back? Well, I'm happy that all of you consider it as a biliary disorder simply because there is no liver and spleen. Excellent. The first part of your thinking process is absolutely right. Now the question is, could it be cholangitis or could it be biliary calculi or could it be a pancreatic cancer? Now, small differences again. If it's a biliary calculi, the presenting feature is a severe colicky pain. This child is lacking on that. Okay, please take a note. A biliary colic is a classical presentation of a biliary calculi or a biliary stones, and the jaundice is a very early in the course of illness. Okay, make again a small difference between when jaundice appears. Okay, now acute cholangitis is a very high fever, extremely high fever. Okay, and therefore this is neither acute cholangitis nor it's a biliary calculi, and therefore a senior citizen without cholecystitis or cholangitis or biliary calculi, but presenting with biliary obstruction, the most common cause could be a biliaropancreatic cancer. And the most common cause is a pancreatic cancer. Okay. Sometimes the pancreas is not involved, but the pancreatic ducts are involved and a biliary ducts are involved, and their common joint is a Wharton's duct. Biliary and pancreatic duct join together. At that point, a carcinoma tumor can start with exactly this story. Age is in favor, absence of high fever, and absence of severe colicky pain puts us away from cholecystitis, cholangitis, and a biliary calculi, and therefore this is typically a biliary tract disease. I'm happy all of you consider it as biliary tract because you are very clear that there is no liver and spleen. It's likely to be a biliary jaundice. Therefore, this was a typical pancreatic malignancy. Can I have the next slide, please? Now, the next slide is that again a middle-aged adult who presented with generalized weakness and abdominal distension for 6 months. Make a note. It's a long duration. The patient has a mild edema of legs. He has no icterus. Okay. And he's looking chronically sick. He has got a large liver, which is firm. It's not tender. The spleen is also enlarged, but there is no ascites. Make a note, chronic disease with mild edema of the legs, but no icterus, and a hepatosplenomegaly without ascites. Your choices are chronic hepatitis, chronic CCF, hepatoblastoma, or a liver cirrhosis. Your time starts now. Well, let's have a slide back. We are very democratically have been equal in choosing almost all four options. Please make a note. This is going on for last 6 months. Okay. And this child has a generalized weakness and abdominal distension. Okay. Please make a note that I have clearly mentioned there is no icterus. Hepatitis, especially chronic hepatitis, has an icterus. So that is out. Okay. Though chronic CCF or hepatoblastoma or a liver cirrhosis will not have icterus. So the first is out. What about chronic CCF? Make a note of this. Okay. The liver is mildly tender, so it could be CCF, but what are the typical symptoms of a CCF going on for last 6 months? There would be some respiratory problem, breathlessness, besides the general weakness. That is lacking. And if it was a CCF, I would have mentioned the neck veins and a hepatojugular reflux, which is not mentioned here. Splenomegaly is possible in chronic CCF, but not common. Therefore, multiple reasons, this is not likely to be chronic CCF. Okay. Hepatoblastoma again presents, but it may not go on for 6 months. It is a cancer of the liver. It's a malignant disorder, and therefore going on for 6 months is unusual, and a splenomegaly is also unusual. To that extent, hepatoblastoma is the localized liver swelling. And being malignant, it is unlikely to go on and on without disturbing greatly the health, and therefore less likely, but spleen is not enlarged. That's an important point. And therefore, this was a typical liver cirrhosis. What we understood by this is a cirrhosis develops jaundice only in the late course of a liver cell failure. Till then, there is no jaundice. But there is portal hypertension, that means splenomegaly, and when the liver cells start failing, you develop not only jaundice but also ascites. So, this child has got what is medically discussed as a compensated liver disease or a compensated liver cirrhosis. So this child has the liver cirrhosis, but I'm again happy that all of you are thinking for all possible causes. But again, the purpose of this webinar is only to bring out small little things to make you aware that how a physician should be very watchful about every clinical sign and also should be very patiently listening to the symptomatology, not only hearing. Hearing is not listening. Listening is understanding, interpreting what you are hearing. And these are classical examples where a good clinician can really score over, even without much investigation, only if you listen, not only hear, and if you observe and not only see. Can I have the next slide, please? Now, this is a bigger boy, 14-year-old, with fever off and on for last 2 months. That's the only symptom. On examination, he has no icterus. His liver is enlarged. It's firm. It's not tender. Spleen is not enlarged, but he has engorged neck veins and the hepatojugular reflux is absent. Please make a note. Neck veins are engorged, liver is enlarged, fever off and on for last 2 months, and your choices are chronic CCF, hepatoblastoma, hepatic tuberculosis, or none of the above. Your time starts now. Well, can we have the slide back? We are absolutely 25% of each. Well, let's look at it in a deeper way. Chronic CCF, yes, looks like that. But why should a chronic CCF has fever for 2 months? Unlikely. Not that it can never happen, yes, but unlikely. And hepatojugular reflux is absent. In a chronic CCF, the hepatojugular reflux is present and fever is unusual. So this is not chronic CSF. Hepatoblastoma is a localized liver disease and it again has no engorged neck veins necessarily. Fever is not a common feature of a hepatoblastoma, but the feature in fact is only the abdominal distension. Therefore, it's unlikely it's a hepatoblastoma. Could it be hepatic tuberculosis? Yes, because you have a low-grade fever off and on for 2 months. But hepatic tuberculosis again does not have the engorged neck veins. It may have everything else that is pushed up in the ear. And therefore, the cause is none of the above. But what is that none of the above? The cause is a tuberculous constrictive pericarditis. Friends, that low-grade fever off and on is tuberculosis, yes. But the tubercle is in the pericardium and the constriction caused by the pericardium is obstructing the superior vena cava, inferior vena cava. It's causing hepatomegaly and causing engorged neck veins because of superior vena cava obstruction. But because it's an obstruction, hepatojugular reflux is absent, whereas in a CCF, there is no venous obstruction, so hepatojugular reflux is present. Again, small differences, but how we could analyze and get a correct diagnosis of a tuberculosis, but not the liver, but a constrictive pericarditis. Can I have the next slide, please? The next slide is again a child who presented with mild jaundice, noticed few months ago, but was ignored because there were no other symptoms. Imagine this 10-year-old child has only one symptom of jaundice, but he has no other symptoms whatsoever. He has a moderate pallor. He has got a mild icterus. He has got a liver which is mildly enlarged and soft, not tender, but the spleen is much more enlarged. There is no ascites. And there is also mild jaundice in the mother also. And she is also fine. So here is a normal looking child who has pallor as the major symptom or major clinical finding. Icterus is very mild and liver is just normal, soft, not tender, spleen is just palpable. Your choice is chronic hepatitis, thalassemia, Wilson's disease, or none of the above. Your time starts now. Can I have the slide back? Almost all of you are right, but also wrong. What does it mean? You are right to say it is a hemolytic anemia. Okay. But take a note that thalassemia is the only hemolytic anemia which has no jaundice. Okay, take a note. Thalassemia is the only hemolytic anemia which has no jaundice, whereas many other hemolytic anemias have jaundice. So this is hemolytic anemia, but not thalassemia. And the mother also has a similar thing. So it's a genetically determined congenital hemolytic anemia. And not only genetically determined, it's a autosomal dominant, which means even a single parent has given this baby the same disease, that is autosomal dominant. Autosomal recessive, both parents had to suffer. And they are not obviously suffering, they have a minor problem. Like a thalassemia major child has both the parents having thalassemia minor. But this is a autosomal dominant hemolytic anemia with jaundice. Therefore, just for your information, I'm sure I'm very happy you called it thalassemia. Okay, because your thought process is right. But I always want to take you at a little higher level. And thalassemia has never jaundice. The reason is the normoblasts, which are the previous stage of red blood cells, before the normoblasts get hemoglobin, okay, and before the RBCs are developed, the cells die out. So hemoglobin dies out inside itself and doesn't come out to be destroyed. And therefore, there is no jaundice. It is known as ineffective erythropoiesis. That's besides. This is typically a genetically autosomal dominant spherocytosis. Forget about it. I am happy you all picked up hemolytic anemia, but today you learned that one hemolytic anemia, which is most common, has no jaundice. Can I have the next slide, please? Next slide, please. Now, the next is a small infant who presented with fever, cold, and breathlessness for 2 days. Has a respiratory problem. Okay, but on examination, you have a tachycardia, marked tachypnea. There is no chest retraction. On percussion, there is a hyperresonant note all over, and you have a liver that is enlarged per abdomen. I have not said liver span is large. Liver is plus plus and spleen is plus for abdomen. Okay, take a note. There are no foreign sound, but there is a percussion hyperresonant note. Child is breathless. Your choice is disseminated tuberculosis, CCF, acute bronchiolitis, or acute pneumonia. Your time starts now. Can I have the slide back? Well, acute pneumonia has many chest signs like bronchial breathing, crepitation. This child doesn't have. And in fact, the percussion note is impaired. This child's got a hyperresonant note, which means there is an air trapping. And because of the air trapping, that's an emphysema, bilateral emphysema. And therefore, this is classically an acute bronchiolitis. And in acute bronchiolitis, because of a generalized emphysema, both liver and spleen are pushed down. They are not enlarged. They are merely pushed down. If you were to look at the upper border of the liver, it would have been in normal situation. Therefore, don't forget that sometimes something occupying in the chest can push down the liver if it's only in the right chest, or push down the spleen if it's only in the left chest. But if both are pushed down, it's almost an emphysema. And cause of emphysema of an acute small infant is an acute bronchiolitis. This could be a story of a chronic bronchitis with emphysema in a middle-aged or old adult, and you might find some liver and spleen palpable out of a bilateral severe emphysema. Can I have the next slide, please? And this is again a child who presented with the increasing abdominal distension for 1 year, gradually increasing. Take a note of that. Gradually increasing, okay, abdominal distension for 1 year. On physical examination, there is a large liver, but the spleen is even larger. There is no other finding. There is no icterus, there is no pallor, no vein, nothing. And your choice is disseminated TB, chronic malaria, storage disorder, or cirrhosis with portal hypertension. Your time starts now. Your time starts now. Start the time. Start the time, please. Anyway, doesn't matter. Doesn't matter. Let's keep the slide on. Okay, doesn't matter. Okay, you got that. Very good. I think go back to the slide. All of you are reasonably right. It's a slowly progressive abdominal distension, and not only the liver but the spleen. So both liver and spleen are storing something, and it's typically a storage disorder. What storage disorder? Forget about it. It's good enough. You have a storage disorder as a clinical diagnosis, and you refer to a right person for further investigation. Can I have the next slide, please? I spent a lot of time because I thought investigations are simple to decide once you have a clinical probable diagnosis. And you know all these tests. If it's an infection, you can look at an IgM HAV for hepatitis A. You can look at typhoid, etc. If it's an autoimmune, you can antibodies. If it's other thing, then do other tests. I will not go into detail. But the liver function test, of course, bilirubin, SGOT, SGPT, protein, albumin, globulin, and a prothrombin time. And of course, then abdominal USG, and then specific liver test including liver biopsy. Can I have the next slide, please? And the management, of course, depends on the cause. And I'm not going to discuss this. Once you have a provisional diet, I think the problem in clinical medicine is to diagnose the condition. The rest is reasonably simple. And therefore, the next slide, please. The take-home messages. I've said this hepatomegaly confirmed by the span. And thereafter, look at a pathological liver, what kind of liver is there. And I talked about hepatocyte, biliary tract, RE cell, venous system, and then microanatomy leads you to a probable disease. I think we have another 4 or 5 minutes remaining, I feel. Back to Anupam. If there are any questions, I would answer. Of course, you will find all the details and will be printed in the GP clinic. Back to Anupam.
Thank you.
Anupam, you are on mute. Yes.
Yeah. Thank you, Dr. Ambekar. It was a wonderful session. So with your permission, I'm taking few questions. If the liver is not palpable per abdomen, how can you judge the consistency, surface, and edge of the liver?
Oh, well, a good question. But first point is, if liver is not even palpable, confirm that the liver is not enlarged, because the liver may be sitting right up to the first or second space in the chest. Something is pushing up the liver. Not common, but always percus. And therefore, it is very, very rare that a liver disease does not have a palpable enlarged liver. That's the first thing. And therefore, if the liver is not palpable at all, just confirm that the liver is not entirely sitting up in the chest. That happens extremely rarely in condition called agenesis of the lung, where there is so much of space vacant that the entire liver and diaphragm has gone up. It happens sometimes when the diaphragm is totally paralyzed and lying right up to the second space. But that is not common. Message is liver has to be enlarged if the liver is abnormal, and therefore there is no problem of not able to palpate the liver. If the liver is not palpable, it's not an enlarged liver.
Another interesting question from Dr. Vinay from Maharashtra. Sometimes clinically we can palpate hepatomegaly, but ultrasound does not mention liver enlargement. Why does this happen?
Yes. See, the ultrasound exactly measures the liver span, because ultrasound can measure the length. But when they measure the length, one, there could be small differences in measurement. Second is, it could be very minimally enlarged. For a clinician, a minimally enlarged is not easy to make out at all and may not be dependable. Further, an enlarged liver is not missed by a clinician unless it is all in the thorax only. Therefore, when clinically you are sure liver is not palpable at all per abdomen, but still the ultrasound says the liver is enlarged, you give a good thought for review again, physical examination, or then consider whether even a sonologist may be wrong. Friends, it's not only a clinician is often wrong. Even the imaging experts are also often wrong. So go by the common thing. There is nothing that ultrasound picks up in enlarged liver that the clinician cannot. Exception, entire liver in the thorax, but that is not common.
Another question is, how can a shrunken liver be suspected?
Well, shrunken liver is not palpable, but still abnormal. And the very fact that it's shrunken means it is not only not enlarged, but it is contracted. That means it does not have even a normal length of 6 to 12 centimeters age appropriate. But don't forget that a shrunken liver is an end stage liver disease. All liver functions are gone. The patient is often in a hepatic coma. He is often bleeding. Therefore, a shrunken liver is metabolically totally deranged liver, and the patient is very serious with hepatic failure. It happens rarely in adults with end-stage cirrhosis. Therefore, shrunken liver is not palpable liver, but metabolically completely washed off liver. And it's enough to say it's a liver disease. It's not only liver disease, severe liver disease, frightening liver cell failure, but without palpable liver, so call it a shrunken liver. In pediatric practice, we never see shrunken liver because a child dies much before the liver has time to shrink. But in adults, yes, the liver may have a time to shrink and the patient is still alive. But by then, the patient is in ICU with hepatocellular failure.
Another question is, can storage disorder present with jaundice?
Yes, I think we have already said that jaundice occurs only when 80 to 85% of hepatocytes are damaged or a biliary tract is obstructed. In liver diseases, when neither of these two things happen, like a large liver tumor could be very large, but it is still not involving 80-85% of the liver, and therefore it will have no jaundice. Plus, if the liver disease has taken a brunt of an RE cell infiltration or a hepatovenous obstruction or a congestion, there is no jaundice.
Not many questions are trickling in. Let us take the one last question. If acute hepatitis presents with jaundice, why does cirrhosis of the liver not present with jaundice?
A good thought. Acute disease of acute viral hepatitis within 24 hours spreads to all hepatocytes, and therefore not only 80-85%, but often 100% hepatocytes are damaged. What is the proof? The SGPT is in thousands, not only few hundred, it is in thousands, because more the hepatocytes are damaged, a larger is the SGPT. And therefore, in acute viral hepatitis, SGPT or ALT is in thousands. It does not suggest any seriousness if the patient is otherwise stable. But on the other hand, in cirrhosis, it's a chronic liver disease, but yet not destroyed 80% of hepatocytes. Less than that are getting destroyed. Therefore, many liver functions are destroyed, like protein production, albumin production. They have hypoalbuminemia, they have portal hypertension, but still no jaundice. Therefore, jaundice acute is a measure of an acute hepatitis with large hepatocyte damage, SGPT sky high. But in cirrhosis, at the end stage, when more than 80-85% of hepatocytes are damaged, you start developing jaundice, and that jaundice is a failure of hepatic disease. So, chronic liver disease with jaundice is a late sign of a hepatocellular failure, whereas acute hepatitis comes with jaundice initially, and the liver functions otherwise are very good.
So with this, I think there are still so many questions are there. So we are coming to the end of the session. And I am sure Dr. Amdekar will cover answers to rest of the questions in print edition of GP Clinic's next issue.
Sure, sure.
Right. So with this, we end this session. So thank you, Dr. Amdekar, for this wonderful session.
Thank
We
you.
hope this interactive session would have made learning interesting for attending doctors to help empower their practice. On behalf of GP Clinics and doctorslive.com, I thank all the doctors who have attended this session. So the date and topic for our next webinar is 17th of November, Sunday, 11 a.m., same time. The topic would be clinical approach to weight gain or loss. So thank you once again to all of you. Happy Deepavali. Good day.
Thank you, friends. Happy Diwali to all of you.